Now let's talk about anticoagulation and subclinical atrial fibrillation. You say, what is subclinical atrial fibrillation? It's noted on an EKG or some sort of device, but the patient is not symptomatic. And this is the Artesia trial, and basically breaks down between apixaban 5 milligrams BID versus ASA 81 milligrams PO daily. And they used 4,012 patients, and mean age was 76.8. That's about the age of most internal medicine and medicine patients. And 8.6% of them had a prior stroke. What did you have to do to get in the study? Patient had to be greater than 55 with or without a history of stroke or TIA with a device noting atrial fibrillation from 6 minutes to 24 hours. So one of the devices, implantable device, a Holter monitor, measured atrial fibrillation from 6 minutes to 24 hours. That was a period. And so what was noted? So if the patient had a prior stroke or TIA, the annual risk rate of stroke or systemic embolization was lower in the apixaban group versus the ASA, significantly, 1.2% versus 3.4%. Now, if they didn't have a stroke or TIA prior, the annual rate of stroke or systemic embolization was much lower, and it was very similar between the groups. Uh, Apixaban was 0.74% versus 1.07%. Now, so it was beneficial to give apixaban with atrial fibrillation noted on device if they had a prior TIA or stroke, which makes sense. And this is in subclinical atrial fibrillation. Now, what is our whole purpose of anticoagulation and trying to prevent further damages from TIAs or strokes? Well, I want you to think about it in the terms of how much time, effort, and depression. If someone has a debilitating stroke and they can't wipe their butt, now think of that if that was you and you're in that bed. Would you be depressed? Would you be happy in your life that you're laying in bed and you have to have someone wipe your butt for the rest of your life? And just think of the costs to have someone or be in a facility where they have to turn you every couple hours to avoid dying from what? A sacral decubus and having the infections related to that, aspirations, all those kind of things that happen. What I want you to always think about, and you can use the terms if you like scoring, is the modified Rankin score. It measures the functional impact of life, of a patient's life after a neurological event, with 0 being no disability to 6 being dead. And then we could say 5 is severely disabled and 4 is moderately severely disabled. That's the modified Rankin scale. Now, those are things that you need to think about when you're taking care of somebody with a stroke, is you're trying to prevent them from having further damage. Now let's talk about antihypertensive medications and fracture risk. This is a specific study done in the Veteran Affairs. I want you to always think when you see a Veteran Affairs study that's been done, they're usually done well, but also the boards likes them. The boards likes them because it usually finds a way of reducing costs. We're talking about antihypertensive medication initiated fracture risk in nursing home residents. This is 13,000 patients, and these patients were followed from years 2006 to 2019. And their average age was about 78 years old. And the primary outcome was composite of pelvic fracture, which we know that's end of times, surgically treated hip fracture, those can be end of times, and fracture of the humerus, radius, and all that require intervention 30 days after starting antihypertensive medications. So this is either a first antihypertensive medication or additional antihypertensive medication given to a patient, and these were the mean average was 78 years old. And guess what the results were? So the people that received new medication, 4.5 out of per 100 person years had falls. And these are serious falls that can be end of times versus 2.2 per 100 person years in the patients where no medication was initiated. Very, very important study that we need to think about before we start initiating new medications in nursing home patients. But if we're going to initiate them, sometimes we have to, we need to check it. We need to check for orthostatic blood pressure. Now, I know normally people check in about 2 minutes, blah, blah, blah. But a follow-up study, this was in 2023, this is New England Journal, and also uh, noted that checking for people at risk for falls and older risk patients need to check orthostatic pressure between 3 and 6 minutes after standing. This is a better way to get a risk assessment for falls in these patients. This is what we need to check at 3.6, and the actual time was 4.5 was the median time that they found was effective in getting information to see if these patients were having orthostatic blood pressure. And this was a great way to tie into this. So if you're going to initiate it, you need to check for orthostatic blood pressure. And you need to do between 3 and 6 minutes after standing is when you're going to check those pressures. All right. This is another study to discuss doing proper blood pressure. In this study, they did the different arm positioning and blood pressure measurements. Just remember, garbage in, garbage out. And I want you to think about in your environment, people doing proper blood pressures. Are they doing it correctly? Because the data they give you is so important for diagnosing and for treatment. And is this data wrong? So what is the proper position? Is the arm supported on the desk with the cuff at the heart level? And usually we read with the right arm, usually. Why we want to avoid misclassifying patients. So in the study, they did about 104 patients. They had hand in the lap, and the blood pressure was 4 millimeters of mercury higher than accurate. And they did an arm unsupported, which is probably between these two is probably what most people do in their clinics. And they're sitting up on the exam table and they have an arm unsupported, their hand in the lap. And this was 6 millimeters of mercury. So it is so important we get proper measurements. And this has to be militant. This has to be where it's everybody who's coming into the facility gets measured the same way. So is it possible? Well, let me tell you exactly what you need to do. And it's almost impossible. The best position to take blood pressure is seated in a chair with your feet on the floor. So think about in the hospital, is that really easy to do? With your arm supported at the elbow and the cuff is at heart level. You should remain in this position throughout the measurement. Okay, now what's the other rules? No smoking or caffeine at least 30 minutes before the test. I'm sure that people are drinking their Starbucks before they're coming in the room. You need to sit quietly for 5 minutes before the test begins. How long does that happen? How long can people sit quietly for 5 minutes now? The inflatable part of the cuff should be cover at least 80% of the upper arm. And the cuff should be placed on a bare skin, not over a shirt. How many times do we do this? Can't talk during the measurement. No talking. Have your blood pressure measured twice with a brief break in between. If there's a difference between 5 millimeters of mercury, need to do it a third time. Well, how many times at your facility are you doing this correctly? So just think about this. Remember, you got to have good data to make good decisions.